Great. Okay. Well, let's get started. As always, we've got our chat box available as part of the WebEx, and so this is going to be a very heavy discussion webinar today, and so you can either come off mute to ask a question or make a comment, which of course is *6 to mute and unmute, or just use your phone's capabilities. We also have the chat box, so you can type your question in. I'll be monitoring it. We also have Lori Choma will be monitoring it. And if for some reason we don't get to all the chat items, they are recorded, and so we will make sure that that we get back to you with your question if for some reason we don't get to it during the webinar today. All right. And just a reminder to mute there if you're not on mute. Hi, good morning. All right, so on our agenda today, we have Mark Watt and Sarah Joy Hagstrom joining us to talk about the family physician. Oh, I'm sorry, it's not family physicians on SENs. That I obviously didn't update that on the agenda on the slide here. We're actually talking about it's a consultation on the continuity of care, and they're going to go into more detail, but they're looking at creating a standard of practice and looking for your advice. So I'm just going to skip past this slide. Here we go. So without further ado, I'll introduce Mark Watt and Sarah Joy Hagstrom from the Alberta Medical Association.
Great, thanks, Michelle, and thanks everyone for tuning in bright and early this morning. I just want to check, Sarah Joy, are you here with us today?
I am, yes.
Wonderful. So thanks for the introduction, Michelle. I'll let you advance, and just because it'll help explain kind of why I'm here talking to you today, hoping to have a discussion. First off, we wanted to share that the AMA Act team has been advancing work on continuity of care as a strategic priority. That's manifested in some developments like the clinical practice guideline, some change packages, some materials to help physicians communicate the value of continuity to their patients. And as part of our work, we've been reaching out to health system stakeholders to help bring them along and help contribute their efforts towards the cause. And so one of the stakeholders that we had reached out to was the College of Physicians and Surgeons of Alberta. And in our discussions with them about continuity of care so that it's aligned to support the patient's medical home, they discovered that in their review cycle that their continuity of care standard was due for a review. And they admitted that very often when they're doing a standard review that they would like to see a broader set of engagement and get more diverse physician voices as part of consultation. And so they had an ask in turn of the AMA is if we could help gather and solicit some feedback that would help them strengthen some of their consultation in their development. So no, the AMA is not developing a standard, the CPSA is, but what we are trying to do is trying to engage more physicians in discussions so that there's more input being provided to CPSA. Let's go ahead, Michelle, thank you. So what it is that we're expecting is to have a discussion here this morning. And so literally I think in the pre-work or pre-reading packages there were like 4 questions we were hoping that you would take a look at and that we would actually talk about today, because while they seem like rather simple questions, depending upon where you are in the system, there might be certain levels of grayness into this, and I think that the more we can tease that out, the better we'll be able to provide feedback. And secondly is this an issue in family physician practice? hopefully we're tackling something that's of importance, but if we look at these and say, actually, this is really not that important, then, we don't have to continue. And so I think, Michelle, we can move forward from here. And again, for those who haven't seen it, this is what the current standard of practice for continuity of care is. I know that we've had some comments that there are some pieces that aren't addressed or aren't addressed well, and that's why we're here. So I think with that, Michelle, we can move to the first question. And so the first question I'd like to get some perspectives on is, what does it mean to have an established relationship with a patient? And some of that terminology seems to imply certain features or certain characteristics. Maybe the supplemental question to that is, is it distinguishable? Are there distinguishing factors around longitudinality, being an episodic relationship, or are there other types of relationships that are important for us to note so that we can be providing that feedback to CPSA? So I'm going to leave it there, and I'm just going to open the floor up to maybe get a bit of perspective on those first questions.
Hi, Mark. Sorry, it's Michelle again. We're just not sure that the chat is working. So if someone wouldn't mind just popping something in there, so we can see if it's actually coming through.
I just did.
Yeah,
me too, Michelle.
Is anyone seeing? See, I'm seeing nothing coming up. Is anyone seeing anything coming up on theirs?
It's Awa, yes. I can see the chats.
You can see the chats? Okay, Awa, I'm sorry, but I think you're the only one who can see them.
Yeah, I can't see them.
I can't see anything.
Yeah.
Because you have to send to all participants. I think I'm getting chats to host, and someone sent to panelists. So you have to choose all participants.
All participants is not a choice.
Or attendees or something?
All panelists is available.
All panelists I did, and it's still not showing. So. What about now? I chose all panelists. Will that work?
And that's what I did before.
I can see them now. Yeah, I can see them now. Thank you.
Okay, good.
I still can only see mine.
Yeah, I can only see mine as well. So we'll have to rely on Lori Choma. The pressure is on to make sure all the chats are shared. All right. Sorry about that. We'll just open the floor back up then to the question.
Yeah, panelists are just the Michelle, Lori, and top schedule. It's not allowing all participants. It's only showing them to you guys, the panelists.
Thanks, Lee.
Okay. Yeah.
Since you have the floor, would you care to comment at this point?
Well, I mean, yeah, this is something I haven't thought about for a while. I used to spend a fair bit of time on it because my colleague Mike Klinkman did a lot of work on this for the World Health Organization, actually. But I do think that there is something different about a longitudinal relationship for two reasons. One, patient expectations. I think patients do expect something different from their doctor, from the physician with whom they have a longitudinal relationship. I think we probably need to explore that something, what it is and so forth, but clearly patients expect something different. They expect more of me, their family doctor, than of someone they've only just seen once in a while. The other reason is the evidence that relational continuity improves outcomes. And that, to me, entails placing a higher level of responsibility on the physician who has relational continuity simply because it's an important treatment in and of itself.
So,
well, I was just going to say, I think there's the family practice where you accept patients and you accept that continuous relationship, and I think we would probably all agree that that's a longitudinal established relationship once that occurs. And then there's the practice that is truly an episodic environment, maybe an urgent care center, maybe a walk-in clinic where you rarely, if ever, see the same person, more than once or twice. I think the college has the most problem with the gray area where it might be labeled as a walk-in clinic or an episodic care environment, yet patients tend to go there all the time for their needs. And, and back to Lee's point, they begin to associate that as a longitudinal relationship. And so I think when the college is defining a standard, standards are meant to be fairly clear and, fairly unambiguous. And so their feedback might be, what are the key features of a episodic versus longitudinal relationship that allow us to differentiate? So I'm wondering what people's thoughts might be on how do you look at a practice and say, yeah, this is definitely episodic care versus this is definitely longitudinal relationship-based care when it's in that gray zone?
So it's Fred. I'm going to weigh in and try to answer this because it's a question of fact. You have to look at every one of them individually. But what I'd like to add in there is I think what we've missed in longitudinal relationships is specialty clinics, like a renal clinic that sees my patients all the time. They have a longitudinal relationship with them. And I can certainly say when the college several years ago came out with the responsibility thing about being available for your patients, I had several specialty clinics tell me, oh, we're not available for patient concerns because patients would never anticipate that they could phone the cardiac rehab program who just bumped their medication up 5 hours ago, or the renal clinic. So my add-in is I think it's a question of fact, and I think that focusing only on family physicians, which is what I am hearing, is missing the boat. There are rheumatologists, nephrologists, you can name them, clinics that constantly see people who have a longitudinal relationship. It may not be the same as a family physician, but it is a relationship, and often the test results are ones that are more appropriately dealt with there. That's my comment.
Yeah, thanks, Fred. So if you think of the specialty environment, and I agree with you, when is it a consultation and a consultation with a follow-up, and when is it kind of a longitudinal relationship? If we were trying to provide feedback to the college on how they would view that.
Yeah, I think there is a difference between a longitudinal relationship and a follow-up relationship. The thing that's critical, and I think you really put your finger on it there, the clinic that just changed someone's meds and then closes and the patient can't reach them, that clinic may not have the same continuity, the same relational continuity obligations that I do as a family doc, but I think they do have the obligation to follow up their own work. And that's actually where I see a lot of the things that endanger patients is exactly that scenario, the specialty clinic that changed someone's meds and then closed and no one can reach them.
Brad?
Mm.
It's Jane. Can you hear me?
Yeah.
Sorry for the voice. I think both of them, the prior speakers, have hit on something really important. First of all, a relationship, an established relationship, is an agreed upon entity between individuals. Okay? And so in Fred's case, the clinic doesn't see itself in relationship with the patient, but I think it was Lee said there is a duty of care because they made a change. So I think that we need to be clear that continuity, an established relationship with a patient in a primary care setting should be defined as one thing. The situations where continuity of care are mandatory should be described otherwise. I don't think that should be described as a longitudinal continuity relationship just because they keep going back to the clinic. Does that make sense?
Yeah, so clearly delineating this is my long-term relationship, place of relational continuity with a family dog is different than, yes, I'm a part of a renal clinic and I have a longitudinal relation with them and they have obligations under the continuity of care standard, and that's different than I'm an episodic provider completely. That doesn't mean I don't have obligations in terms of continuity of care either, but they might be different. Okay.
Hi, it's Tina here. I absolutely agree with what's being said here. I think one of the things that I've heard come up when I've been doing some work with some groups through the work that the PLP does in helping facilitate physicians in understanding a paneling process and that sort of attachment. And one of the stumbling blocks was the term most responsible physician, and whether that equates to the same thing as the identification of the patient-medical home relationship or exactly what we've just been talking about. So in that specialty clinic where there obviously is an established relationship, there will be a most responsible physician for that area of care, which might actually be quite outside the scope of practice of the primary care physician. But yet there is still a medical home where, if you like, that's the backstop. That's the place that the patient possibly would expect all the information to feed back to, even if that is as somebody who has to advocate for that patient to ensure that continuity continues. So I think you're right, it becomes this grey area of when does that, I think that's the need for clarity, is when does that care transfer? I know from the paneling perspective, just one more thing on the medical home, one of the things that physicians were stumbling with was the only question was to the patient as to who they identified as their physician, and it was not a reciprocal question. So it was the patient identifying their most responsible physician and not that physician recognizing that that was one of their validated patients. That's another little twist in the tail.
Yeah, I'm also, sorry, we're just wondering about the last question on here, can multiple docs have the same relationship? So sometimes you see a clinic that says, well, we look after these 5,000 patients as 3 docs, but none of us are assigned to any of those 5,000 patients specifically, yet we have this relationship with them on an ongoing fashion. So the question is, are those all, do they share the responsibility for continuity? Is it assigned on the last person you saw? Is it assigned on what basis? So can multiple people hold the same relationship at a clinical site?
Brad, it's Heidi. One of the things that I use to kind of think about this is the idea of a quarterback. So who is the quarterback for the patient, or who has a quarterbacking kind of role and a care coordination kind of role for the patient for their overall care? And so, can a clinic have that role? Yeah, I think a clinic can have that role. Can a family doc and a pediatrician both have that role? Yeah, I think they kind of can. It's a little bit difficult at times to decide that. One of the things I've encountered lately is, I now have a couple of post-transplant patients, and I feel like I don't no longer have that quarterbacking role for those patients, that the transplant clinic has pretty much told me to go away and taken over that role for those patients. So that's one of the concepts that I kind of use when I'm thinking about this. But again, you have to be careful then in the gray areas or in walk-in clinic medicine. When does that become when does the continuity become the walk-in clinic's relationship? They may say, well, I'm only a walk-in clinic, but what does the patient think? So I think that's where that runs into some difficulties.
It's Tina. I totally agree with what you're saying there. And the danger of there being 3 or 4 quarterbacks is that each of those might think that the other one, unless there's a very clear transfer of that responsibility, this is exactly, I think, what we're talking about. And that's the communication piece, isn't it? And possibly in some cases a misunderstanding, and maybe this is from the patient perspective. I think probably we all encounter the perception from the patient is that there is a very free flow of information, and that we will always be informed irrespective of what that encounter has been. And yet that doesn't happen unless we literally go look for it. So I think it's the transitions that are most important of who is dealing with what, even if there are different quarterbacks for different areas of that patient journey.
Michelle Warren here. I do think that when you're looking at continuity of care, having that quarterback or that sort of primary family physician is important. But then I also think if that physician's not available, sort of the next best thing is continuity within the clinic. For exactly that reason, there is that sharing of information available to your colleagues that, you have the same EMR, you're able to access those notes, that sort of thing. And I think we're kind of, when we're looking at the patient's medical home model, it's not just the physician that's the patient's medical home, but all of those care providers, be it a nurse practitioner, social worker, whoever else is within that medical home. So I do think it can be, but it's, I don't know football would be like the secondary quarterback or something like that.
The backup. So you can think of, was it Winnipeg that used the 2 quarterback system, and each had defined roles, and it worked just fine, right?
So I love the analogies, but the follow-up question then becomes, in the backup quarterback scenario, there's only one of them on the field at a time. So what would be the distinguishing feature of a quarterback, or how would accountability lie when there are multiple quarterbacks or multiple supporting team members involved in care?
So this is Oliver, David, and I'm just, we're talking about what we feel the relationship is, and I think at the end of the day, it's the patient that identifies who they feel their most responsible physician is. And they may say that, I go to this clinic and I primarily see Dr. Jones, but sometimes if I need to, I'll see Dr. Smith. And I think that needs to be part of this discussion. I agree with everything that's been said, primary, backup quarterback, first string quarterback, some guy, the third string quarterback who's sitting on the bench. But I think at the end of the day, I've heard from patients that, you are my primary doctor. Sometimes if I can't get in to see you, I will see Dr. X, but you are the person that, when I see Dr. X, I still come back to confirm that was okay.
Yeah, I've also practice shared in the past, Oliver, where there was actually 2, truly 2 docs sharing a practice, and that can work too. But so I think all of it goes back to communication about roles. So when I was in that practice share setting, I had to have regular calls with my partner to say, okay, what are we doing about this patient? Okay, what's the plan, So it was doable, but just like a specialist family doc relationship where both have areas in which they quarterback for the patient, it requires clear communication about roles and responsibilities. And the difficulty I find comes when the docs don't know that there's another quarterback in the process. So the patient has arranged something, but I don't know that the patient is, sees a walk-in clinic regularly for quite a few of their health concerns and that sort of thing. So, that's where it gets troublesome and gray to me.
Absolutely, because I've heard scenarios where they say that I see so-and-so for my diabetes, and I see you for my, whatever else, and I see
this doctor for my women's health needs. my pap smear, my breast exam, and all my gynecological stuff goes to this doctor, but I see you for everything else. Or my favorite one, I have a walk-in clinic. My favorite one was I have a walk-in clinic in Airdrie that's much closer and more convenient to me. But you do a better job of mental health, so I come to you for that. That's my favorite one.
What becomes the provider obligation to define their role? All right.
So, Brad, you've nailed it in that we're blurring responsibility for things like results, follow-up, screening, etc. If we're going to define responsibility, I don't think relationship and responsibility are the same thing, and I think we need to get very clear.
I think that's the clearest statement. Yeah, definitely. And I would say
I agree.
That I would say that that the responsibility comes down to the understanding that if that patient is seeking a periodic or episodic care with either a clinic or an individual, that they have to transfer that back to the primary physician. The fact that they have seen them. So that would come if you go back to Heidi's bit where people do gynecological care. I do gynecological care for some patients who are not even in our clinic. I will write a consult letter back to that primary care physician so that they know what I have done. But I don't think that is not what always happens. We know that doesn't always happen.
I think that really hits the nail on the head, though. If a physician
Hi, this is Yvonne Kangong.
What's that?
Hi, this is Yvonne Kangong. Can I just shed a light on that?
Sure.
Can you hear me? Yeah. So I would agree with you totally. Like the issue, I do work for the college with the group practice review, and the issue of episodic care comes up all the time. And that's why we have to encourage the patient to see one family physician. Sometimes it might be really hard, but I think you as a family doctor, you know your patient. There are times that patients come to me and all they say is, I'm here for my prescription. And you look at them in the face and you say, there's something else going on. Let's have a conversation. Because you've known them for a long time and you know when they're okay and when they are not okay. But if they go to a walk-in clinic, they're here for the prescription, they're just going to give that to them and out they go. So I think we have the role of encouraging the patient to stick with one physician. And if they're not able to see you, if you're not available, if possible, come to the clinic so that we can have record of the encounter. And if not, whichever doctor they see, if they can just remind them to please send the information over to the family doctor, I think it's very important. That way we're closing all the loops and things don't fall through the crack.
Thank you. Lee, you want to just say something?
Yeah, I think the critical thing becomes that a physician who does not intend to establish that longitudinal relationship with the patient is obligated to hand off the information about what they've done to the physician who does.
So part of that continuity standard has to include what's the continuity responsibility for episodic providers, and it should be, transfer of information back to the family physician of record. Van, do you want to say something?
Yeah, just in driving here and listening to you, Brad, I would say that our clinic was that prime example of, because we're an inner city clinic, patients are episodic, but we have a lot of patients who attach to us as well. And so we had this, big challenge with, we were able to panel a good chunk of patients, probably not a good chunk, probably only about a third, to be honest. And the rest of the 2/3 were just coming in and out, not because, they didn't want or they were seeking walk-in clinics elsewhere, but because they were just too, unstable in their lives. And I could see this applying to clinics that serve primarily the youth population as well, or clinics where docs are part-time, like 1 or 2 days a week or 3, and that's a reality. We have all these different scenarios where, the gold standard or the, we strive to aim for one doc all the time, but the reality is that doesn't fit with a lot of patients, and so our clinic has had struggles with that. So what we've done is we've almost like categorized or stratified our whole entire clinic panel into, a third of them are, yes, identified with a primary care physician or nurse practitioner in our case, in our clinic. And then we have about a third of our patients who we've labeled in their EMR. It's like CUPS as their health home. So we looked at their return visit rate. So we looked at data actually within our clinic and in our EMR, and we pulled how many times they were coming back to CUPS and set a standard. So if they were coming back to CUPS twice a month, clearly they weren't going anywhere else, we didn't think, right? Because they were coming here for all of their needs. And so we then grouped those folks as high return visit rate folks, but not being able to or not wanting attachment. And so we labeled those as CUPS Health Home. And so CUPS as a clinic, we agreed as a group of practitioners how we were to care for them. And then so you had to have good communication and meetings and all this stuff with your practitioners, including your frontline staff, what to do with those patients, because we can't let those guys fall by the wayside in terms of screening and all of that. They were clearly coming to us for help. And then we're trying to kind of pilot a practice share thing because our docs are part-time, so having shared panels in addition to all of that as well. So, lots of challenges.
So the key there might be you had an internal agreement on who holds that responsibility, and that might need to be part of this. And then, I heard some stuff about we need to define the role of the patient in defining, what's a continuous relationship or longitudinal relationship. I'm going to hand it back to Mark and try and let him get through another set of questions here.
Great, thanks, Brad. I think building kind of on that theme around the differentiation between responsibility and relationship. So now one of the things that we want to get some perspectives on is around when testing or diagnostics are being ordered on patients, but in this case, the longitudinal care provider is not copied on the tests that were ordered by that individual. Where does the responsibility lie there in that type of a scenario?
I think there's continuity and then there's clairvoyance, and this is expecting clairvoyance from primary care without any support to do this. So, I don't think you can reasonably expect without systems supporting this type of information transfer that we can predict when this exists or what happens. Like, I don't feel like you can expect responsibility from somebody about something they know nothing about.
I would agree with that. It's Jane.
Hi.
I think that if a patient receives a request for an investigation or a test from any physician, if that physician isn't going to be available to follow it up in a timely fashion, which I believe the college would say is their responsibility because they ordered it, if they're not going to be available, there must be a transfer in an appropriate fashion of both the fact that it's going to be done and the report to the primary care physician. It should not be left to the primary care physician when the patient shows up 2 weeks later to interpret a test that was done 10 days ago by someone else in emergency that they went back and got done the next day. There has to be a closing of the loop to the primary care physician if we can accept responsibility for all of that care.
Hi, it's Tina here. I agree with that. I think that right now this area is a little bit of a mess, and I think that it can actually create a lot of unnecessary work. I've recently been dealing with a patient who had come into the clinic in Fast AF, and I sent them to urgent care. Urgent care stabilized them, but then elected to do a referral to cardiology, but didn't follow through on it. And the patient is now a month out, and it's been my staff chasing this down, chasing a referral that wasn't done, when I'd actually been in a position where I wanted to put that referral in quickly. So you end up with a situation where you're almost, you could duplicate, or this could fall through the crack completely. And then I think the other piece is when we get our communications back from specialty, and there might be a statement that will say the patient should have, a repeat CT in 6 months, say, but they don't clarify who is going to be responsible for organizing that. And then again, because you've got this letter and you've read that, your staff has to then chase up and say, okay, who's going to do that? Is that you or is that me? So I think that it's back to communication, and it's back to clearly defining who is doing what piece of this patient care.
Is there, just on that theme, is there broad advice that a group like CPSA could give, whether it's maybe not in the standard, but maybe in some interpretation documents? Is there a default that this group would feel comfortable putting forward at this point, or is it about that negotiation on a case-by-case basis?
I think there's already some decent language around this in the referral consultation standard, Mark.
Great,
and
thanks,
it comes down to the communication, and I can't quote the language, but it does already talk about being clear on whose responsibility for follow-up things are and stuff like that. So,
but we hear that it's a test system right now. So is that sufficient? And so what else? So if the current that exists today, but we still have this challenge, what else would be required? What might be a requirement to help improve this?
So to Heidi's point, the problem is the standard of care, the standard around continuity talks about the patients we're responsible for. The standard of care and referral talk about what people are doing with patients, but they don't say what happens in between. So Tina pointed to some of them. I think the other piece is the important part, that if it's my understanding, and if I'm correct, please correct me, that if a physician orders a test, that physician is responsible to ensure that it's dealt with in a timely fashion. It doesn't matter whether you're their continuous provider or not. If you order a test, that's your responsibility. If you are changing that, there must be some kind of referral, note, communication, clarity to the primary care physician that they will be responsible. That is not delineated anywhere.
I would suggest that just like when you get together on a committee meeting and some poor person is taking the notes, the most efficient way of running a meeting is to have action items which are clearly defined and are allocated to the person, and there's a timeline put there as well. That way, everybody knows what's happening. And unfortunately, we don't do this terribly well in medicine. It's a little bit fluffy. So I think that despite the standards that we've already got, the actual itemized piece and the clear delineation of responsibility is not always there in the written reports, and maybe that's what needs to be clarified.
I think we also need to be careful that it's not a dump as well, though.
Yeah,
like people need to take care of their own stuff and not always dump on the primary care physician. And then my other point is that these standards, like in the referral consultation standard, it does say you're supposed to address who's responsible for follow-up of items. And the problem is we can't fix professionalism issues with more regulation. So I think we have to be careful that we don't continue to regulate the good providers who follow the standards when the people who don't follow the existing standards continue to get away with it. So I think we have to avoid burdening the docs that are already conscientious further without doing something to address the ones that aren't conscientious.
Great, thanks, Heidi. I'm just going to go to the chat line, and Lori, you have some comments?
We've had a couple comments in the chat box. I don't know if you wanted to remain anonymous, so I'll just say Dr. J. We've had many instances of patients seeing walk-in docs and only actually sees the family physician annually. This suggests maybe a need for a new or another definition of a therapeutic relationship. That's the first comment.
And then the second comment, with the proposed cuts to primary care, we will likely see an expansion of the, quote, one concern per visit, unquote, and logically more frequent visits to walk-in clinics. What then in this scenario constitutes continuity?
Okay, so thank you for those. I don't know if there's any other feedback you want to provide on those comments, but I'll kind of keep this moving along, and if you want to, then that's great. So I wanted to now flip the question a little bit in terms of responsibility when you are copied on some results that you did not order. And this time it might not be from a physician. This might be from your PCN nurse who's operating under some protocol, so you've referred them to the program, and they're doing some continued investigations, and you're now being copied on results. So where does the responsibility lie in that type of a situation?
And is it different if it's an allied health team member or it is a specialist?
Yes. Yeah.
Okay.
Is there differences there?
I think it's definitely different. If it's an allied team member as part of one of the programs that I referred them to, I still consider myself to be primarily responsible for those. And that may differ depending on the program and things like that. But, you know, if I'm copied by a specialist and the jurisprudence is clear, if that result is significantly abnormal, even if I don't know who the patient is, if it's sent to me in error, I still have a responsibility to ensure that somebody knows about that and is taking care of that. But barring those situations where there's something substantially abnormal or whatever, you know, I tend to expect the ordering provider to take care of it. But if it's one of my longitudinal patients, it kind of forms the backdrop of, you know, my knowledge about the patient, and I may address it at their next visit. But unless it's substantially abnormal, I tend not to take immediate action on it. I don't know what others' practices are.
It's Tina here. I think sometimes your prior experiences maybe influence what you might do with some of these things. One instance I had was receiving a pathology report on a skin biopsy, and it was a biopsy that was done by specialty, and it was a malignancy. And I did chase up with the patient to make sure that the patient had follow-up, and they hadn't had any follow-up done, and that other provider hadn't either noted the report or acted on the report. So when I get those pathology reports, I must admit I might do things differently with something like that would be a malignant skin lesion that needed actioning. I might just double check and make sure that follow-up is done over maybe, you know, a different pathology report that has been done in a different setting. So, you know, that's where it becomes grey, because you might not act the same in every situation.
I do exactly the same, Tina. So if I get a significant pathology report back, like something like that, I've had the same thing happen. It was a melanoma in situ that never got any follow-up. And so, you know, those ones I count as significantly abnormal, and I manage those differently than, you know, a TSH from the endocrinologist, for example. Yeah. Yeah.
Any other thoughts or examples from the group?
So we went through the college review last year, and we run a walk-in for most of our patients, actually, and many people come from other clinics. And the college discussed with us the continuity of care. And so the approach that we take is that when somebody enters the clinic, there's a question right on the top of their sheet. Who's your family doc? Do you want your results sent to your family physician? And clearly, you know, many patients come repeatedly to the walk-in, but they don't go to the family doc except very rarely. So that's one approach. Something I've thought about with this pathology or anything else that somebody orders, it's kind of interesting, you know, when people look and they say, well, I saw a specialist, you say, well, when did you see them? Well, I saw them 3 weeks ago. Well, what were the results, or did they order? Oh, yeah, they ordered some tests. They said you can look it up on Netcare. And I'm going, well, how would I know you were even there?
Yeah.
And I've had some significant carcinomas missed because I didn't get the pathology report. And actually, I've thought about this for a while, and it actually can be built into the fee schedule. If you see a specialist, and the specialist does not CC you the MRI result, they lose 10% of their consult fee. And I'll tell you, you'll never see faster and more inclusive results copied to everybody until, you know, the primary care physician gets that. And then you start getting that information, you get that continuity, and it's done overnight. It's like a low-hanging fruit solution.
Brad, so a couple comments on that one. One, the billing system, at least as it currently exists, has no mechanism of doing that. So that's not technically possible. But two, I think we have to be careful about what we wish for, because I actually don't want every single lab result done on every one of my patients, because I don't have capacity to deal with that. I think we have to think about I want the MRI that was done, but do I want every single routine lab done in the transplant clinic on my patient? No, I really don't, actually. So I think we have to be careful about what we wish for in that respect.
I think I would echo that. I don't think it's necessarily relevant if someone's going to the walk-in clinic for a respiratory infection, but I think the bigger challenge is when people have standing orders, and renal does a lot of standing orders, and a lot of different clinics do standing orders. And it's not exactly clear when there's an abnormality like an elevated potassium who's actioned that, or if they haven't actioned that. That's where it's a bit blurred. And I've heard apparently that from one of my nephrology colleagues that they actually are still working off a lot of paper. So presumably Connect Care would help with that, but there's certainly risk finding that out and going, okay, maybe I have to be a little bit more diligent with some of those renal standing orders, because there's always that chance when it's on paper it may not be actioned the same way.
I'd like to let Mark get to the last question. So
I was going to just make sure I have time. This isn't the one and only consultation, but this is the last question.
I think you could at least throw it out there, and if people have thoughts, they could think about it and send it your way, but at least get it out there.
Yeah, thanks, Brad. So we might not do this one justice, but is there a professional responsibility around communicating the type of relationship with the health system? So we've said that relationship maybe doesn't equal responsibility, but as we're hearing in terms of expectations of receiving information, and how would people know? Well, how would people even know what type of relationship? So I'm just going to throw this out there. Like, is there a responsibility, and if so, what is that responsibility around communicating those relationships with the system?
I think, first of all, there has to be an ability to do so before you can consider creating a responsibility to do so.
This is Lee.
And
this is much deeper water than it looks like. This actually is what Mike Klinkman spent several years working on for the World Health Organization. And the best I can say, we probably should just like get his white paper and pass it on to them. This actually turns out to be really, really difficult.
Great. Thanks. We will follow up to get that.
It's Tina here. Having done half my career in England, where essentially family physicians are allocated patients, and you have one set of primary care charts that follow you cradle to grave, there is no ability to seek care from more than one primary care provider unless there is a consultation piece in there, and the consultation piece. So if a primary care physician is engaged by one of their colleagues for a particular area of care, then that is a consult which is treated just like any other consult and requires a reasonable transfer of information back, and the relationship is quite clear. We're not in that system, but that is a way of helping some clarity, but it's very difficult, and it has to involve the patient. It's also who the patient identifies as their physician if we're talking about primary care.
Yeah, so it's Oliver. What's the role in the healthcare system to tell patients, in a publicly funded system, to tell patients that they need to be attached to a primary care physician?
I'll add that question. That's a great question too.
So you're asking about whether or not there should be a responsibility to notify the system. So to Heidi's point, if there's a reasonable way of doing so, if it's somehow tied to your billing, and considering what the government has thrown out recently, that's upsetting primary care physicians, that the only physicians who can bill a complex care plan or complex modifiers are the physician to whom that patient is most tightly tied. And that needs to be an agreement between physician and patient. So I think the system's responsibility is to find out what the patient says. I don't think it's the physician's responsibility to find out what the patient says, but there needs to be a way for physicians to say, these are the patients I'm willing to be responsible for. And then everyone else in the system must respond to that individual with appropriate. So, Tina, you made a great comment about the UK. If a patient went to emerge in the UK, the family doctor would always be notified. So maybe we should look at how hospital and ER care is dealt with, because if it were dealt with as a referral, the doc wouldn't get paid unless they communicated back to the primary care physician. Just a thought.
Yeah, Connect Care is actually, now whether we have it working the way we want it to or not is another question, but Connect Care is actually, when it's working properly, set up to automatically send discharge notes and ER discharge notes to the primary care provider. So that will potentially help in that communication piece. But you have to be able to indicate who the primary care provider is in order for that to work.
Thanks, Heidi. Go ahead, Tina. One last comment.
No. I was just going to mention one other thing, which is the current allocation method that is put into place, and it's subtly different. So what the patient thinks, what the physician thinks, but then, for instance, what that paneling process, whether it be a 4-cut method, 5-cut method, what are those prongs that the college then allocate a patient to you with? Because those allocations are different than potentially what either the physician or the patient might agree on. So they don't necessarily align. And I think that's just a throw-out comment to say that actually the systems we've got right now don't necessarily attach us in the same way all the time.
Thank you, Tina. And thanks you, everyone, for your comments. I think this will be very helpful in, I think the words were be careful what we wish for, so we'll be very careful in terms of how we start to word some of these discussions. So thank you. I think I'll turn it back to you, Brad, for the...
I was just saying I think some of this requires longer discussion with more groups to sort through what our advice would be to the college. But thanks for the conversation. Michelle, do you have some final kind of reminders before we sign off?
I do have a couple, yeah. So again, thank you, everyone. Those are some fantastic insights, and we were recording the call, so we'll send out the recording to you. But just know that we have captured all of your great comments and insights. A reminder: hopefully, all of you can make it to the PCN Strategic Forum. The theme this time is scaling up, and that is in Calgary, February 7th and 8th. And it's a bit of a new format this time, so we're hoping that you'll come and experience it with us. Also a reminder, if you haven't checked it out, the podcast on PMH in Alberta, available on all of your favorite podcast vendors. And again, if there's a topic that you would like to talk about or one that you would like us to record with someone else, just get in touch and we'll make it happen. We have set our dates for the 2020 webinars. Expect to see some invites coming out in your calendar reflecting these dates. And we will continue with our Wednesdays at 7 a.m. format. And my email address is there. You can always just reply to emails that come out to you if you, again, have any comments or thoughts or ideas about what you would like to have covered in those webinars. And then lastly, just until next time, we wish all of you and your families a happy holiday and all the best in 2020. So thank you, everyone.
Thanks, Michelle.
Thanks very much.
Thanks.